Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me again is Dr. Rylan Johnson. Dr. Johnson is board certified by the American Board of Foot and Ankle Surgery and Reconstructive Foot Surgery, as well as reconstructive rear foot and ankle surgery. Am I missing something out of there, Doctor, from last time? Did I cover? I don't want to miss anything.
Because those are my board certifications.
These titles are always impressive, and I love to be able to rattle them off. Last podcast, we had you on talking about bunions and lapiplasty, and that was a very fun conversation to have. And I think if anybody's considering a surgery for a bunion, that's the way to go, and they should get in contact with you, right away. I think another foot issue that a lot of people are familiar with, but what I was curious about this, doctor, is specifically how you know that this is plantar fasciitis. Okay, that's what we're going to be talking about today. Sure. Because I'll get up in the morning and take a step, and maybe it's just like, oh, I'm older. That's why this hurts. Right. Okay. But let's really quick, what is plantar fasciitis? Right.
Well, I guess I think it makes sense to talk about what is the plantar fascia first.
Yes,
right?
There we go.
So, the plantar fascia really is this kind of more of a supportive structural role in the foot. Okay, and it's not a tendon, it's not a ligament. It really is kind of a band of tissue that helps support the architecture of the foot. And in a non-weight bearing capacity, the fascia is loose. It doesn't have any strain. But as you bear weight on it, it becomes more biomechanically and there's more tension placed on it. So it really is an overuse injury based on activity, even weight bearing. So, so a lot of times when patients are, start a new exercise regime or maybe kind of do something slightly out of character that they're not used to, the plantar fascia can be strained. Kind of like a tendon can, but the plantar fascia can be strained. Now, the plantar fascia insertion and the greatest amount of stress is always at the heel. So a lot of times plantar fasciitis is described as heel pain. And so patients will come and say, I've got this heel pain, or I've got this heel bruise, or this tenderness on the bottom of the heel, not the back. That's more Achilles tendon territory, but the bottom of the heel. And that's usually plantar fasciitis. I usually tell patients, if you have plantar heel pain or heel pain at the bottom of the heel, we almost have to prove it's not plantar fasciitis.
Oh, really? Okay.
Because it's so common.
That was going to be my question. It must be so many people must experience this then.
So common.
Why doesn't it, we need our feet to get around. Right. We're constantly on our feet. Sometimes we don't make good decisions with our exercise or our shoes or things like this. Right. Why doesn't it seem to happen to everybody? It seems like it would. It seems like that tissue would be just the most overworked tissue in the body.
And I guess it does happen a lot. I think a lot of times we tend to live lifestyles that are different than what we used to. I think a lot of us are sedentary a great bit of the time, and then we decide to be active. And I think those abrupt changes in activity are sometimes hard for our foot to make those accommodations for. We can sit at a desk all week long, and then on the weekend comes, I'm going to go play basketball. Right. Now, that sounds like a good idea, but your foot might disagree, okay? And so a lot of times your foot is not conditioned for that. It's just not used to it. And so you can take your body off guard if it's not conditioned for that level of activity with some regularity. And so, you can strain your plantar fascia. And one of the things that patients, sometimes you don't always feel it when it happens. What happens is you'll get up the next morning and, there's that heel pain.
So is it generally something that happens in the morning? Is that
I think in early stages, it is oftentimes pain after a period of rest. We call that post-static dyskinesia. And that's usually when you kind of get up after a period of rest. It can be first thing in the morning or maybe after lunch when you sit down for a bit. And what happens is the fascia kind of tends to contract and develop some inflammation. When you get up, now all of a sudden the fascia is back in a mechanical stressed state. And that's when you feel the strain.
So what position does it rest best in on your foot? What position feels normal for it?
Well, weight bearing. I think it is intended to be weight bearing. And so that's a lot of times when you're sitting, It's not.
Right.
You're in a seated position or you're sleeping at night. The fascia doesn't have any strain on it whatsoever. And then if it is strained, it'll contract. It'll actually contract and develop some inflammation. So, I mean, a lot of things we do to address plantar fasciitis conservatively is to stretch it. I really focus on a lot of stretching activities and tell patients, continue with these stretches. It's that weekend warrior thing where we're catching the fascia off guard. We kind of get some consistent stretching in the interim between those levels of activity. A lot of times the fascia can be a little bit more conditioned and ready for those abrupt changes in activity.
So it's on the heel, kind of on the bottom, you said. And is it like little tears, like micro tears? Is that what you're feeling?
I think it can.
Okay.
Initially it can just be inflammation.
Oh, okay.
I think in the early stages of plantar fasciitis, it's just insertional inflammation, of which it can resolve with time. If it becomes more chronic, you can have micro tears in the plantar fascia. And in those types of situations, the fascia can become not just acutely inflamed, but also degenerative. And I tend to reference that as more fasciosis than fasciitis. It's just where the fascia, if you were to ultrasound or do an MRI, you'll actually see thickening of the fascia and fluid within the fascia. And that is actually, you're seeing some of those micro tears and some of the edema within the tissue. Prognosis on those is more difficult. Because now the anatomy has changed some, and you're not just dealing with the acute bout of inflammation that that can resolve very quickly. Now there's some chronic changes involved.
Can it tear completely?
It can. It can.
I can't imagine that.
A plantar
pain.
fascial rupture is definitely possible.
Sure.
Unusual. It's a very robust structure. It really is. It's a very, very, very solid structure. They don't tear easily.
Okay. Now we talked about bunions being hereditary in a sense, correct?
Right.
Is this too? Can this be? Is it? Common?
I find it more consistent with certain foot types.
Okay.
A higher arch foot or more of a pronated flat foot deformity, those types of feet will have greater strain or hypermobility on the fascia. So I think sometimes your foot type may predispose you to having more plantar fascial strain, which can then create some inflammation.
Okay.
But I don't think it's necessarily kind of like a bunion where, you're going to get just, you can see that in young children.
Right.
Even, like a juvenile hallux valgus.
So is this, when it comes to, what's worse, a flat-footed person or the high arch for this sort of thing? And can you explain those really quick, just the difference between those two?
Sure. Yeah, if a really high arch foot, we call pes cavus, those tend to, you can still have quite a bit of plantar fascial strain with that type of foot. A lot of times the fascia is almost bowstrung on those types of feet where it's really tight. Whereas if your foot drops, gravity kind of takes place, you get this pronation where the arch drops. And you can imagine the fascia also can have strain.
Sure.
I think the strain on the pronated foot type is more mechanical, where I think strain on the higher arch foot type is probably more just if there was a hereditary component to it, I see that in those high arch feet. Those structures are just genetically tight.
Okay.
Like in a high arch foot.
And you talked a lot about one way that you kind of alleviate this is stretching, that plays a very important role in this. What other mechanics or things for your shoes or feet or whatever help? So
when I see somebody that comes in and sees me for plantar fasciitis, I always kind of begin what I kind of call tier 1 of treatment. One is kind of explaining the condition and letting them know the plantar fascia is it's a cry for help. So what we need to do is provide some help, and so we stretch this. The fascia is tight, it has strain on it. We need to stretch it out real well, and I go on some plantar fascial stretches, on calf stretches, ankle stretching type techniques. Another way we can provide help is with shoe gear, And so you can have shoes that participate more than others. So I usually try to go towards more of a stability shoe, a shoe that's going to absorb energy through gait instead of transfer it. So you want more of a stable shoe, a little bit of a rocker, 4-foot stable shoe. And a lot of that, and most of these are athletic shoes or running shoes. Those are the shoes that are meant for kind of repetitive, high impact, high velocity. Those shoes can handle a lot of mechanical stress when you're using them.
Right.
And so a good stable shoe will also help the foot. And then it's an arch support and orthotic, And so can we reduce stress off the foot by independent of the shoe, and that's kind of helping the plantar fascia with its job. The plantar fascia's job is mechanical. So if we can get an orthotic in under that foot, we can provide that supplemental reduction of stress, through an insole.
Boy, I mean, the more I think about this, you said it's, that it's not a muscle, it's not a tendon, it's a tissue.
Yeah,
it seems like a really fascinating part of your body. And the fact that how often is surgery necessary for something like this? Does it have to be really bad, I would assume?
Yeah, usually surgery is reserved for the people who have had this a long time, where we definitely know this is not an acute problem. This is a chronic degenerative fasciosis, where if we were to do an MRI, we'd see fascial thickening and degeneration and maybe even some micro tears within the fascia.
Then how do you fix that then in a surgery?
Well, there's a couple options. Traditionally we would do partial plantar fasciotomies. And what that basically would imply is that if you have a structure that has a lot of strain on it, you can release some of that strain by cutting a portion of the fascia. Okay? And that had been the standard for a very long time. And I still do that procedure on some foot types that I think the fascia is really tight, like a pes cavus foot.
Okay. Wait, what is that? Or
a high arch foot.
A high arch. Okay, perfect.
Yeah. So we know the fascia is just bow strong. It's just tight, 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 tight. I think a little release can kind of go a long ways.
Okay.
You got to be kind of careful with release, just because the fascia does have a biomechanical purpose in the foot. It's never a complete release. It's enough to kind of alleviate some strain, but leave enough for biomechanical function. What we're doing kind of now also, or in addition to, or depending on what's going on, is we'll try to debride the fascia. Okay, so if we realize the fascia is degenerative, a lot of bad tissue, we want to get some of that bad tissue out. And so we'll actually do a debridement of that. And there's a couple ways we've done that over the years. I do a procedure called 10X right now, which is actually an ultrasound guided debridement of the plantar fascia. So,
that was used a lot for tendons, isn't it? Is that procedure used, but it can work for this
fascia
weird tissue in your foot?
Yeah, the fascia is kind of like a tendon.
Okay.
Mechanically it's slightly different, but I think the general idea is similar enough that we can use that same kind of modality.
Okay.
So I use 10X for a debridement. It's a small incision. It's percutaneous. We can kind of identify the diseased tissue on ultrasound, and we can debride it. We can debride the diseased tissue from the area. A lot of times I'll follow up with that with what we call a PRP injection, which is platelet-rich plasma. So after the debridement, I will oftentimes spin some of the patient's blood, take the platelet layer, and then inject that into the debrided area to help as a catalyst for healing of the debridement.
Okay. Now this is for people that have tried everything else and the pain never goes away.
Right.
What is the pain like on this? I'm pretty sure I've never had this.
Yeah.
But it's enough to just drive you a little crazy?
Well, I think, early on, a lot of times it's first step pain in the morning. I mean, it's sore in the morning, and then you can kind of walk it off and do all right, and then you might go to lunch and kind of have that increased pain again. As you have it longer, we're talking months, years even. A lot of times when I'm seeing patients for these surgical debridements, they've had plantar fasciitis for 3-4 years. Okay, and at that point in time, the first step pain in the morning is no longer. They just kind of hurt all the time.
Yeah.
And of course, they can hurt more with activity because you're just walking and stressing this diseased tissue. So it can change over time. The acute plantar fasciitis is different than the chronic plantar fasciosis. So they do kind of morph and change as the disease process in the tissue increases in severity.
But this seems like something that if you pay a little bit of attention to your feet at all, and you do some stretches, you're just careful with the shoes that you wear, that this could be something that you never experience as long as you pay enough attention to your feet. Maybe?
Yeah, it's a good question. It is a good question.
Yeah.
I had one bout of plantar fasciitis once upon a time.
Oh, really? Okay.
And I always say I kind of stretch my way out of it.
Yeah.
And I find it really is a flexibility thing, and that's why I really focus on stretching, because that's addressing the problem at its root. I mean, it's tension. Right?
Outside of that,
stress.
Then what else do you recommend outside of stretching?
Well, the shoes insoles.
Okay.
We do a lot of orthotics. I think orthotics are very powerful in reducing plantar fascial strain. I mean, you have a nice custom orthotic built, you are supporting the foot so the plantar fascia doesn't have to be working so hard.
That'd be my next question. I mean, over-the-counter type inserts?
I think it's a good start.
Okay.
It's a good start. I would recommend that you kind of go to more of an athletic store to purchase those.
Oh, okay.
Because, the really soft foam gel things like that are nice and soft and cushiony. But I always say a marshmallow is cushiony, but it's not supportive, right?
Dang it. They are so comfortable.
Right, yeah. So, cushiony is not always support. There's a difference.
Okay.
And what we need to do is not just find something that's cushiony, because that's, like I said, a marshmallow is not supportive. Right. So you do want to find something that's kind of semi-rigid. And then the trick is trying to find something that matches your foot. Okay?
I see.
Because everybody's got a different foot, and like every arch support in a box is going to be the same.
Right.
So which one matches your foot? Which one is going to work well with your foot structure? It may not be the one that your friend likes.
Yeah.
It'll be something completely different. And that's where a lot of times custom orthotics are helpful, because we can ensure that you're getting the appropriate fit. Even left versus right, if there's subtle changes, it'll pick up on that.
Okay.
The thickness of the polymers based on your body weight, everything about it is based on you. And so you can dial that in. And the longevity of a custom orthotic. I have custom orthotics that I use still today from back when I was in residency back in like 2005.
Oh, wow. So they last a while then.
Yeah, they can, if they're made of a nice hard polymer plastic and they're structurally supportive,
sure,
they will last a very long time.
Do you have any, I might wrap it up this way, do you have any things that you just absolutely shouldn't do, or you see people, because again, you can get on social media, and I was watching a guy, and maybe I'd love to ask you this question. He said, here's how you fix plantar fasciitis. So he takes a spoon and he rubbed lotion on the bottom of his feet. And he said, you don't use the curved part of the spoon, you use the edge, and you just scrape it up your feet until you feel the bumps, and then you work those out, and you do it, and he said, you'll feel great.
Yeah.
Is there any merit to something like that?
Well, I think there is.
Really? Okay.
Well, I think soft tissue manipulation can increase blood flow. And so that's what that is. And so, a lot of times I'll send patients to physical therapy. Okay. Mm-hmm. You send that for fasciitis, tendonitis. And therapists oftentimes will work on stretching. They'll also do ultrasound and deep tissue massage, and even, really get in there and manipulate the tissue. What that's doing is bringing attention to the location. It's telling your body to, hey, let's pay attention to this spot, because blood flow to these structures are poor. Okay. You can cut the fascia and it does not bleed. Blood flow to these structures are poor. And so by bringing attention to that, either with an ultrasound, deep tissue massage, you're increasing blood flow.
So then it's all good, really. I mean, in that sense.
And that's why, part of the stretching we talk about, I even tell patients to, grab a tennis ball or a racquetball and roll it under your arch. There's merit to that.
Sure.
It's a deep tissue massage. It's going to bring attention. It's going to increase blood flow. It can stretch the fascia. All those things are positive.
Have you ever seen anything that you just roll your eyes at and you're like, don't do that? That's the dumbest thing I've ever seen. You ever come across things like that?
Well, I think a lot lot of things have some merit. You know, it's just a matter of trying to oversell it. I think
you're right.
So, but yeah, you could. But yeah, I think a lot of it is I think. If you're, I think a lot of times patients will get plantar fasciitis when they are doing something that their feet are not accustomed to doing. And that's really part of it. I mean, if we all walked 5 miles all the time,
right.
5 miles wouldn't be a big deal. But when you sit all week and then on the weekend you hit it, it's that weekend warrior mentality that kind of gets you, and you're going to catch your foot off guard.
Excellent.
And I think that's where stretching is very important, because you can kind of fill in the gaps a little bit and gain that flexibility, so your foot is ready for the activity of which you're going to be participating.
You mentioned calf stretching in there too. Does that play a little part into it, or does that just kind of go with the whole?
No, it kind of goes with the whole thing.
Okay.
Yeah, the calf muscle, Achilles tendon, plantar fascia, they're all in cahoots with one another.
Got it.
And
okay.
really, if you have a tight calf muscle and you don't have enough dorsiflexion of your ankle, if your calf is really tight, you will have plantar fascial strain. Yeah,
really?
Yeah. So when you're walking, if your ankle can't come up, you're distributing your weight forward, and your ankle is tight, your plantar fascia will have increased strain. And so they're all biomechanically very much together.
Okay.
And so when we stretch the plantar fascia, we are stretching the Achilles tendon and the calf muscle as well.
Okay.
Because biomechanically, like I said, it's hard to differentiate them.
Okay. So yeah, if you're going to get up this weekend and go do something, stretch. Get a nice orthopedic in there if you need one.
Yeah, wear appropriate shoes for the activity.
Right.
Don't wear the cute shoes if you're going to go hiking.
Or as I'm hearing, just don't exercise as much, and then I don't have to worry about this. Anyway, Dr. Rylan Johnson from Monument Health. Again, thank you for coming in and talking about this. It's been a lot of fun. I appreciate it.
Thanks for having me.
You bet.